Hello, my name is Sandra Lynn. I am a professor and senior vice director at the Johns Hopkins School of Medicine, Department of Otolaryngology. I am in the Division of Rhinology and direct our otolaryngologic allergy services. And I'm pleased to be presenting the Rhinology Worldwide video textbook portion on allergic rhinitis, the principles and practices of immunotherapy. Today, we'll be discussing allergy immunotherapy, what it is, who are good candidates for allergy immunotherapy, how does it work, the two main forms of allergy immunotherapy that are available in the United States. Again, then we'll review the key points, and then I will share some just suggested readings that will give you a more comprehensive view of this topic. So first, what is allergy immunotherapy and how does it fit into the treatment paradigm of allergic rhinitis? Well, when we talk about the treatment of allergic rhinitis, it's usually a three-pronged approach. One is avoidance. For example, if you have a cat allergy, avoid cats, but this can be difficult to do in real life, for example, for such things as environmental pollens. Next, there's very effective pharmacotherapy for allergic rhinitis, such as nasal steroids, oral antihistamines, and topical intranasal antihistamines. And finally, there's allergy immunotherapy, which is the only hope of actually changing one's immune response and modulate the actual disease. So in those patients who have symptomatic allergic rhinitis, you need to confirm the diagnosis first by taking the history and performing appropriate skin or in vitro testing. And in those candidates who are appropriate, administering allergy immunotherapy with a very controlled amounts of allergen that the patient is sensitized to over a long period of time has the effect in those patients of decreasing allergy symptoms and medications. In addition, it can also prevent new allergic sensitizations and prevent the development of allergic asthma. And there are some important things to point out about patients who are appropriate candidates for allergy immunotherapy. The first is that they must have symptomatic allergic rhinitis with documented IgE-mediated allergies, either by skin testing, such as prick testing or in vitro testing, and there's correlations between the symptoms and the positive allergens. Patients may also be suffering from allergic asthma, and the typical allergy immunotherapy candidate is not well controlled with environmental avoidance or medications, or they may not be able to tolerate the adverse effects of pharmacotherapy. Some patients want to, for example, in young patients, want to prevent the development of allergic asthma and new sensitivities. And frequently patients come and say, hey, I want to do something different to actually change the disease mechanism of what's going on, not just treat the symptoms. Also very importantly, there are people who are not candidates for allergy immunotherapy. One is those patients where you cannot actually prove an IgE-mediated allergy via testing. Patients who have really poorly controlled asthma are not good candidates because allergy immunotherapy can actually provoke an asthma attack. Beta blockers are a relative contraindication, as if patients are to have a severe systemic reaction to allergy immunotherapy and need epinephrine, taking a beta blocker can make the control of anaphylaxis difficult. Pregnancy is a contraindication for the initiation of allergy immunotherapy, but patients who are already taking immunotherapy at a maintenance dose can continue safely. And what are the forms of allergy immunotherapy that are available in the United States? One is tried and true subcutaneous injections. These have been used in the United States for about a century. There are also sublingual tablets, which are made by the large pharmaceutical companies treating specific allergens. And then there's also a sublingual AQUEOUS or allergy drops, which is an off-label use of those allergens that are approved for injection immunotherapy. But how does allergy immunotherapy actually work? Well, the repeated exposure of the allergen leads to immune modulation, and it actually increases the tolerance to the allergen, and this tolerance is lasting, so that even when a patient, after doing a full course of immunotherapy, continues to benefit from that treatment with immunotherapy. There's an allergic immediate response and late phase response, and allergy immunotherapy blunts both of these and helps therefore control symptoms. We can actually see immunologic changes in patients who've undergone allergy immunotherapy. These can be divided into 4 categories. You can see decreased activity of mast cells and basophils. There are new allergen-specific T and B cell regulators that develop. In the tissue, you can measure that there is a decreased number of eosinophils and mast cells. And finally, there's changes in allergy-specific antibodies that can be measured in the serum. So for example, when we have a patient who has undergone allergy immunotherapy, we see several things, particularly antibody changes. You can first see an early increase in the allergen-specific IgE, followed by a late decrease over a year to 3 years. And you can see an increase in the allergen-specific IgG4 early. And so you can actually measure that a patient is having a response through the serum. And finally, if you skin test a patient who's been on allergy immunotherapy, you typically will see a decrease in skin reactivity. So I'd like to start talking about the most long used form of immunotherapy in the world, which is injection or subcutaneous immunotherapy, or the abbreviation is SCIT that we use. It is given in a physician's office to the appropriate candidate based on their positive sensitivities, based on testing and history. Typically, patients get weekly injections, and over the period of 3 years, then it can extend to monthly injections. And a typical course of full immunotherapy is 3 to 5 years. There are some cluster and rush dosing, which allows you get to monthly dosing much more quickly, but you have to do very frequent injection at the beginning. And these patients who've finished a complete course have continued symptom and medication reduction after discontinuing. I just want to present some things that our group had found in a large systematic review that we performed of randomized controlled trials. We found in subcutaneous immunotherapy close to 8,000 abstracts and did full article reviews on 1,800 articles, and found 74 randomized controlled trials with over 4,000 participants. And we wanted to examine in a systematic fashion with this review the efficacy of subcutaneous immunotherapy for inhalant allergic rhinitis. And what we found is that in each of these categories, looking at the strength of the evidence, strong of course being the best and low being the worst, that there is very strong evidence that subcutaneous immunotherapy in allergic patients helps control allergic asthma, rhinoconjunctivitis, and disease-specific quality of life. In addition, allergy medication use, there was moderate strength of evidence, and there was evidence for decreasing combination medication symptom scores, but this was not as strong as for the other categories. And then what about the safety of subcutaneous immunotherapy? Because, when we're administering immunotherapy, we're actually provoking an immunologic reaction. When we talk about reactions to subcutaneous immunotherapy, they can be divided into local reactions, which are referring to those reactions at the site of injection. For example, there can be what we call large local reactions, erythematous, swollen, tender areas that can develop. And you can see it can happen pretty frequently in patients with subcutaneous immunotherapy. If they're very large, the physician may choose to more slowly advance the patient's strength of dosing. You can see systemic reactions, which are reactions that occur distant from the administration site, and they can vary from skin reactions such as urticaria to nausea to headache, GI upset, wheezing, so can affect almost any body system, are rare, but anaphylaxis can be a result. And you can see that there are fatalities that have occurred in the United States. And in this study, it was one for every 2.5 million injection visits, there was a fatality. So subcutaneous immunotherapy is not without risk, although it's very, very safe and very, very rare. But you need to be aware and have your office prepared if you're administering subcutaneous immunotherapy for any potential anaphylactic reactions. And what patients are those that might be more at risk for having anaphylaxis and a fatal outcome? Well, in looking at the literature, patients with uncontrolled asthma, those in which there were mixing errors where the immunotherapy vials were mixed by the office, patients who were not given enough epinephrine or there was a delay in giving them epinephrine, patients who have had a history of prior systemic reactions also are at increased risks. And these reactions also tend to happen in peak allergy season. So to be aware of these, to know and identify in advance potential high-risk patients is important. And what about from the practical standpoint, for subcutaneous immunotherapy? So as I mentioned, the injections are done in a physician's office. Most physicians' offices who do a large amount of subcutaneous immunotherapy are mixing based on the positive testing results, and you're starting with a dilute amount of allergen, escalating until a maintenance dose, and then go in a maintenance phase. And as I mentioned, there's a traditional escalation, which starts with, typically year 1, weekly subcutaneous injections, year 2, every other week, year 3, going to once a month. There's also cluster and rush, in which in a very short period of time, over a period of a week or 2, you're giving escalation up front so that you can get to that monthly injection and patients do not have to come to the office as frequently. And after an injection is completed, the patient should be observed for 20 minutes in the office because of the potential for systemic reactions or anaphylaxis. And typically, most offices would probably recommend patient carry an EpiPen in case they have some delayed form of anaphylaxis. Patients who undergo subcutaneous immunotherapy typically need to have 6 to 12 months of treatment before they really see a significant impact on their allergic symptoms or see a decreased need for allergy medications. So moving on to sublingual immunotherapy, and this is exactly as it sounds. It is given under the tongue. And as I mentioned, there's 2 forms. One are tablets, which are from pharmaceutical companies have developed these, and then the off-label sublingual aqueous or allergy drops that can be mixed from those allergens that are approved for subcutaneous immunotherapy in the United States. In other countries, they do have approved sublingual aqueous allergens, but as of the time of me recording this presentation, those are not available in the United States. So sublingual immunotherapy is started typically in the physician's office, but then given at home. Most regimens are daily. And there are two primary types of dosing schedules. One is to just give the same dose year round for the therapy. There may or may not be an escalation phase with that. Another regimen are what we call pre-co-seasonal. For example, for ragweed, which is in the fall, usually in the United States, you start the ragweed tablets for approximately 16 weeks before the season and continue through the season, and that's called pre-co-seasonal dosing. The recommended duration is somewhere between 3 to 5 years, and again, just like injection immunotherapy, after a full course, there's continued benefit and positive impact. And how effective is sublingual immunotherapy? Well, our group also looked at the effectiveness of aqueous sublingual immunotherapy, and we found over 8,000 abstracts, about 1,800 full articles that yielded 63 randomized controlled trials with 5,000 patients that we performed a systematic review of the literature. And what we found is that similar to subcutaneous immunotherapy, there was good evidence in all of these categories. The most strong was in allergic asthma, but also moderate strength evidence in rhinoconjunctivitis medication use, combined medicine symptom score, and disease-specific quality of life. So that there is good evidence that sublingual immunotherapy controls the symptoms of allergic rhinitis and allergic asthma. And as I mentioned, there's also sublingual tablets. In the United States, there's 4 tablets available: Timothy grass, a grass mix, ragweed, and dust mite. And when we look at the efficacy, and all of these look at improvement over the placebo group in symptom medication scores, you can see that the efficacy is 30 to 38% in Timothy tablets, 28% greater improvement over placebo and grass mix tablets, 21 to 27% for ragweed, and about 17% improvement over placebo in symptom medication scores. So there are tablets, and these can be very useful for patients who have, maybe 1 or 2 of these allergens that are their primary drivers, so that these tablets are available for patients. What you also can see is there are a lot of allergens that are not treated by tablets. We do not have tree pollen tablets available in the United States. And so there are some things that the tablets cannot treat, as well as animal dander. So some of these are very common allergens, but we do not have tablets available to treat them. And what about the safety of sublingual immunotherapy? Again, split reactions into local, systemic, and then the worst systemic, which is anaphylaxis. Local reactions in sublingual immunotherapy are when patients can have irritation in the mouth, or sometimes they have a little itching under the tongue. And you can see it's really very frequent. And some studies show up to 84% or even more of patients have some local reactions when they first start sublingual immunotherapy. These tend to typically dissipate over time once a patient has some more immune tolerance. Systemic reactions are rare in 0.05% of doses. And because of the improved safety profile in comparison to subcutaneous immunotherapy for anaphylaxis, sublingual immunotherapy is, that is one of the reasons sublingual immunotherapy is allowed to be dosed at home. And you can see the estimated non-fatal anaphylaxis is 1 per 1 billion doses of sublingual immunotherapy. So what about sublingual immunotherapy safety? I pulled these items from the tablet inserts that are included with the products. They recommend a patient have the first dose of sublingual immunotherapy in the physician's office with 30-minute observation, prescribing an epinephrine injector for these patients, since they'll be dosing at home. Patients who are not good candidates: uncontrolled asthma, prior severe sublingual reaction, prior history of eosinophilic esophagitis. Only for those who are pregnant if very clearly needed. And they also say here, Beta blockers are a relative contraindication. In practical administration of sublingual immunotherapy, I'm going to walk you through what we do in our office, and I know many of my colleagues do the same. The first dose is given in the physician's office, and then patients do daily home administration. This is, again, mixed off of patients' histories, correlating and confirming with allergy testing. Some people may have an escalation phase or no escalation phase, and I don't think there's any clear consensus. For example, some of the tablets, there is no escalation. Because it comes in one dose. We had talked about doing daily year-round dosing, and some products, for example, for pollens, may utilize pre-co-seasonal dosing starting about 4 months before the season and continuing through the season. There is a very, 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 very low risk for anaphylaxis, and that's why we allow them to dose and at home. And what's a duration until we actually see some impact on symptoms? Typically in 4 to 6 months, patients on sublingual immunotherapy will start to see improvement in their symptoms. So I've talked about the two main forms of immunotherapy available in the United States. And the question always arises, for example, when we talk to patients, well, which one is better? So in this very recent publication, compared house dust mite injection, SCIT, SLIT tablets, SLIT AQUEOUS. And well, the good news is that all of these were effective as all forms were effective in decreasing allergic dust mite symptoms and decreasing allergic medication use. But for symptoms, there was an advantage to subcutaneous immunotherapy over any form of sublingual immunotherapy. And the tablets and the aqueous appear to be about equivalent in their symptom control in these meta-analysis they performed. What about for allergy medication use? Well, in this case, that the subcutaneous immunotherapy and aqueous SLIT were about the same, but subcutaneous immunotherapy seemed to have an advantage over sublingual tablets. So perhaps when you look at, and this is kind of reflective of some of the some other articles trying to compare, there may be a slight advantage to subcutaneous immunotherapy, particularly in symptoms. But I think the advantage of sublingual immunotherapy is that for some patients, it is easier to do, and they may be more likely to take it because they can dose at home or more easily comply. So some of the key points I just wanted to really share with you today and review is that whatever the form of allergy immunotherapy, it is a very effective treatment for patients with demonstrated IgE-mediated and symptomatic allergic rhinitis and allergic asthma. It is the only therapy that can actually modulate and change the immune reaction of the allergic patient to an allergen. Both subcutaneous and sublingual immunotherapy are effective in controlling allergic rhinitis and allergic asthma in symptoms, and you can, things such as pulmonary functions for allergic asthma improve with both forms of immunotherapy. In addition, immunotherapy can also help prevent new allergic sensitivities or the development of allergic asthma. So, for example, may be really helpful for a highly atopic family that has a young child to try and maybe prevent the development of asthma. When we think about safety, sublingual has an improved safety profile in regards to severe reactions such as anaphylaxis, which allows for home dosing, but very typically the first dose is given in a physician's office. Subcutaneous immunotherapy, while very safe, there have been reported fatalities, and while extremely rare, this necessitates that subcutaneous immunotherapy should be dosed in a physician's office. And after the administration, be observed for 20 to 30 minutes in the office to make sure there's no systemic or anaphylactic reactions. As far as comparing the two forms of immunotherapy, subcutaneous immunotherapy appears to have an advantage over sublingual immunotherapy in symptom improvement. Thank you for sharing some time with me today. I had put on each of the slides some of the references if you would like to review them. If you want to get a bigger overview on allergy immunotherapy and how it fits with allergy testing, etc., I would recommend the International Consensus Statement on Allergy and Rhinology. It is published in the International Forum of Allergy and Rhinology. Right now, there is an update in progress, which should be out in 2023. And this consensus statement takes a critical eye and really looking at the evidence in allergy immunotherapy, both sublingual and subcutaneous. So thank you for sharing some time with me today, and I hope you found this useful and familiarizing you with the role of allergy immunotherapy in treatment of allergic rhinitis, some of the principles and some of the practical concerns. Thank you.